Okay. Oh, yeah, we do have people coming in.
You know, you need 3 people. You have 3 people. You are obligated to give a lecture.
You're sitting on a 24 at the moment.
No. And here they come.
It's fast. It's according to my clock. It's a minute to 20. Now it's exact 20.
Oh, I'm always a little paranoid about these things actually working. So I like to have just a little bit of buffer for.
Me to have enough of a better experience in past with equipment not working or springs. So as you notice, I prefer to have everything checked.
And of course, all that time in Switzerland, at 12 o'clock in Switzerland, boom, they start.
Yes, sharp.
Sharp.
It's not like in Mexico, you know, Mexican time or Italian time or Spanish time. It's more flexible.
Yes, but the Swiss, I've never met such precision. I know why their watches work because their whole life. Boom.
Well, I was only the lectures in Switzerland, so I do not have your experience. So I have a Zoom which is allowing for more than 45 minutes, a professional Zoom.
Yeah, we can go for hours.
Yeah, the same with me. No, like our courses now on Zoom are 5 days, 8 hours a day courses. So it's quite challenging. We just
it would
have
be challenging to do 8 hours on a Zoom meeting.
So we're switching with Margaret. No, we're not talking 8 hours each of us. We're trying to divide, but I have a chunk of 4 hours or so sometimes, and we have a demonstration as well. So we're showing, for example, demonstration of a counseling or initial interview and so on. Now I start recording, okay, demonstration or so it's easier. But I agree that it's challenging. I'm typically brain and physically dead after a course like this.
And I think for attendees, it's hard to sit and watch a Zoom presentation because in person, I think
I agree with you, but because of COVID and another thing is, for example, during class course, we have 2 people from Australia. For them, it was easier to switch day and night for 5 days, but travel to United States, stay, be awake during a few days of a course and get back. And we have people from all around the world on our Zoom courses. So, but positive and negative aspect. Margaret definitely prefer a course in the clinic. We have a course in the clinic with a special room and so on. But courses on Zoom has some positive aspects too. By the way, do you hear me well, or should I switch different microphone?
No, you're fine. I can hear you fine.
Great.
They can hear. Yeah, the audience have said they can hear you fine.
Great, because you know, sometimes because of unknown reason, I can use the microphone from, as I'm now using from my hearing aids. I try to behave as a good patient and recently start using hearing aids regularly. Or I have a microphone in the camera, I have a microphone in computer. So there are 3 options plus setting. But if you are hearing me well, that's lovely.
Well, I am going to, since we are 5 minutes past, if anybody hasn't arrived, they will. And I do want to thank everybody for coming today. I'm Dr. Lisa Stirrup. I'm president of Hearing New Zealand. And Hearing New Zealand is the registered charity representing the community voice of people with hearing loss. So our goal of Lunch and Learns is to increase the knowledge of hearing and its problems. Today's speaker, Dr. Joel Jastreboff, has probably forgotten more information on hyperacusis and misophonia than most of us will ever know. Dr. Jastreboff has written the seminal book on hyperacusis, misophonia, phonophobia, and I urge all of you who want more information on the topic to read it. So, as the subject is so vast and our time so limited, Dr. Jastreboff is going to give an overview, particularly on misophonia, which is the least known of all the conditions he was telling me. So if you have any questions, and we will be asking for questions and encouraging questions, feel free to put them into the chat. We have Catherine monitoring that. And if you have any questions, feel free to use the chat for that one. And with that, I'm going to turn it over to Dr. Pawel Jastreboff. Thank you for coming.
Thank you very much for invitation. And I strongly believe that population issues which are a little bit complex, like misophonia, hyperacusis, alternatives as widely as possible is of great benefit for everybody. So today I will be trying to present a very brief and very general outline what misophonia is and how it linked to hyperacusis and decreased sound tolerance. So I'm Pawel Jastreboff, and I'm now Professor Emeritus of Otolaryngology at Emory, and now I'm working in Jastreboff Hearing Disorders Foundation. The best way of reaching me, if you'd like to, is just this email address. I strongly recommend not to go to my webpage because it's really very old and not good, and I never had time of doing anything reasonable with this. But this email is the best way for reaching me if you need it. Okay, let me see. Is it working? Yes. So the issue of decreased sound tolerance is a little bit complex and can be confusing. You have a lot of different sounds and category of the sounds which people don't like and which evoke some negative reaction. You have a number of loud sounds, and everybody knows them, power tools and so on. But as well, many people and many patients are just stating that some specific sounds and sounds which are not actually very hard can be bothering them, like cat walking on the hard floor, or sound of eating, high-pitched voices. And you have a long list of those sounds which are reported to be bothersome. And please notice, and this will be something which is important to realize, that sounds which are bothersome do not need to be loud. They can, but not necessary. And another point is, which creates some confusion, is issue of reaction reported by patients. I have a long list of reaction, both emotional and purely physical, including, for example, pain. And the issue is that if you try to classify the sounds which are creating problem by reaction, you fail. It's not any regularity that certain sounds are inducing given type of reaction and other not. And I will be trying to argue that those reactions actually are a result of an overstimulation of our part of our brain, autonomic nervous system. what is being done? Most frequently, using earplugs, headphones, covering ears, leaving the play situation. Some people are actually trying to mimic Babelson sound, particularly in case of sound of eating, repeating, for example, these words, and using headset with music. So you have a lot of things from one point of view, decreasing level of a sound or avoiding sound, or using loud sound, one sound to cover the other sound. Now, from a point of a treatment, something what professionals are doing are not patient. Very frequently is ear protection recommended. Medication, but mainly for anxiety and depression, and so far there is no medication which has been shown to be effective for tinnitus, hyperacusis, or misophonia. Or you have exposure therapy, like in case of phobias, using sound to decrease sensitivity of auditory system, creating a positive association, variety of a form of counseling, including cognitive behavioral therapy, which are getting more and more popular for treating tinnitus, hyperacusis, misophonia. You have a biofeedback, you name it. It's a very long list of therapies, which majority of them, when they are tested more carefully, turn out to be not effective. So for over 30 years, we're using tinnitus retraining therapy. It's a method which was initially created for treating tinnitus and hyperacusis, and since 2000 was modified to treat misophonia as well. So how misophonia came into the picture? I started seeing patients in 1990. Previously, I was just basic neuroscientist without any interest in the clinical aspect. So once I started seeing patients and trying to use TRT, which was introduced at the very end of the 80s, we recognize, in this case, that means Margaret, that about 60% of tinnitus patients have a decreased sound tolerance, but majority of them actually react negatively only to specific patterns of sound, frequently, although not always, associated with specific situation places. For example, sound of eating, chewing, swallowing, voice of specific people, clicking sound, high-flying airplane, or hum of refrigerator. And what was interesting, what was puzzling, that at the same time, this patient could tolerate even high level of other sound, for example, loud music. So they were not fitting classical description of hyperacusis, at case of which it's assumption that the sound is louder but certain threshold. This is creating problem. So we coined the new term misophonia. As you know, if you don't have a new name, the phenomenon does not exist. So we decided to create some term, and with help of my friend from Cambridge University, Cambridge, England, Guy Lee, we create term by asking him to provide like a list of prefixes from Greek or Latin, which we can combine with a sound phonia, which describe voice sound, to create something indicating negative something. So misophonia literally would means hate, is from Greek, of sound, but definitely should never be translated as a hatred of sound, which unfortunately some professionals did. The same as photography is not translated as a drawing by light, or chromatography as a drawing by color. And it was introduced the term in 2001, initially in Audiology Online, and then in peer-reviewed journal in 2002, in Australian and New Zealand Journal of Audiology. in which the first protocol for misophonia was presented as well, which we were using successfully since then. Now, in this classification, phonophobia is specific case of misophonia when fear is dominant emotion. Now, just a little bit about patient, misophonic patient. So patient with misophonia will respond strongly, mildly or strongly, to soft sound with specific patterns and meaning, for example, voice, sound of eating, but not react to other much louder sound, for example, loud music, sound which convey more energy. And another thing is the person may react to given sound differently in different situations. For example, reaction at home versus reaction at office. If a sound is generated by, let's say, mother or father of patient versus by colleague. And as well, the reaction depends on the non-auditory factors like previous evaluation of the sound or some beliefs that sound is potentially offers some threat. In case of phonophobia, overexposure will be harmful, but this is not necessary. Majority of the patient, misophonic patient, realize that sound as such is innocent, but they have a very strong reaction. And model which we propose, which I will show you in a few slides, is trying to explain why it is so. Sound might be and frequently is associated with previous negative experience. Psychological profile of patient might have some context, but misophonia, again, is physiological, not psychological problem. An explanation and treatment for misophonia is coming from physiology, not psychology. So definition, just very brief definition. So we have one word, same plane. We're proposing definition of decreased sound tolerance as existing when subject exhibit negative reaction of any kind, whatever it is, as a result of exposure to sound that would not evoke the same reaction in average listener. And decreased sound tolerance is a result of summation of effect of hyperacusis and misophonia. And the reaction for both hyperacusis and misophonia are basically identical or very, very similar. Please notice that this average listener is similar a little bit to the defining what's a zero at audiology. Now, from a point of view of a definition, behavioral definition, I strongly believe and I promote the idea that definition should not be based on any presumed etiology or mechanism. It should be based on observation, and then we can create a definition which are based on proposed mechanisms. So from the point of a behavioral definition, hyperacusis, negative reaction to a sound which depends only on its physical characteristics, spectrum intensity. Misophonia, negative reaction to sound with a specific pattern and meaning. Physical characteristics are secondary or not important. From point of a mechanism which we propose and which we publish, and hyperacusis results from abnormally strong reactivity of auditory pathways, subconscious auditory pathways to sound, which only in turn leads activation of emotional and autonomic system. And misophonia results from abnormally strong reaction of those systems, but resulting from enhanced function connection between auditory and other system of the brain. And I would like to point out that we're using limbic and autonomic nervous system, but they're not the only system which involved. But involvement of those two systems allows for explaining feature of misophonia and as well proposing both misophonia and hyperacusis and proposing its treatment. Epidemiology. It's a lot of disagreements actually, and prevalence of hyperacusis, for example, varies from 9% to 86%. Our observation that about 60% of patients with tinnitus have some decreased sound tolerance, and 2/3 or so of them is actually misophonia. Using information from literature and from our clinic, from our clinical observation, and we probably, no, not probably, we've seen nicely over 1,000 misophonic patients, and a few hundreds of hyperacusis as well. About 2–3% of general population have a clinically significant decreased sound tolerance. That means person is looking for a treatment. As you see, it's quite a large number, which unfortunately is very underestimated. Only recently it is recognized. And again, hyperacusis misophonia exists for people in all ages, but misophonia tends to occur rather younger population. Now, I listed just to show you that, although I'll be not talking about details of it, it's a number of neurophysiological concepts which are behind the proposed models of misophonia and hyperacusis, and I would touch upon only two of them. Automatic gain control and principle of contrast, although all of them are heavily involved, for example, conditioned stimuli, brain plasticity, and so on. So let's start. Automatic gain control. All sensory system, vision, hearing, works on principle of automatic gain control. That means the gain depends on the strength of sensory input. You have a weak sound, the auditory system is amplifying this, and we have the data from animals and as well from humans showing that indeed is happening. It's giving maximal dynamic range of perception, and unfortunately is adding something distortion. The problem is if this system starts to be working incorrectly. This here we have auditory pathways, and it seems what we are proposing that hyperacusis, not misophonia, but hyperacusis, reflect abnormal amplification in the subconscious part of auditory system. Results from clinic are showing that actually we are not seeing, there are no data showing that amplification in cochlea, which might be provided by famous outer hair cells, plays role. So rather it is here, and there are some animal data that dorsal cochlear nucleus, inferior colliculus are involved. So on this block diagram with the auditory system, the limbic system, autonomic nervous system, hyperacusis is claimed to result from over-amplification here in the subconscious part of the auditory system. So treatment, obviously just recalibrate the auditory system, and by exposure to continuous sound or sounds with different properties, you can achieve reversal of hyperacusis. And its famous pink noise therapy proposed by Vernon in the 80s with some specific protocol seems to be working. We're using different version of this or different implementation, but in case of a hyperacusis, this method seems to be quite effective. Now, how to distinguish between DST and hyperacusis misophonia? I would like to point out that audiological evaluation is not sufficient, and we do not have a good questionnaire which really allows to do this, so extensive case history is essential. And just to show you what we are dealing with, I would like to present just a few cases what patients were describing to us. Then by the way, all those cases were treated very successfully. So all of those cases we get a substantial improvement or even cure. So first case, May 27, normal hearing, healthy. And if it's something in quote, that means basically it's a direct quote of a patient. It started at age 8 from sound by the older sister. Other sounds included chewing gum, lip smacking, slurping, sound of kisses in the air by other people. Sister was just basically pretending that he's kissing him to make him irritated, because she noticed that he was just getting mad at her. But problem gradually increased. Now it has 27, and started be bothered by a number of different sounds, the sound of the kisses being one of the dominant. And he felt reaction, was able to inhibit his external manifestation of relaxation, what he was feeling with. And even expectation of the sound or visual triggers reacted as well. He tried by pediatricians, psychologists, the different version of psychology. There was no positive effect of this. Case 2, 16 years old, female, normal hearing, healthy. And it was a very interesting story, which actually is quite typical for a number of the patients. It started 4 or 5 years ago when she was 12. And grandfather moved to the house, had denture falling out, and he was making noise when he was eating. It was really very unpleasant. And at the beginning, he developed very strong reaction to this grandfather, but gradually it spread to other family, particularly mother, and other sound like swallowing or eating popcorn became a big problem. But she has no problem with sound when she is with friends. So in this case, it's related to people. And this actually can be very nicely explained by concept of complex conditional stimuli. So he was trying Zoloft, and basically it did not help even for anxiety. She was pretty desperate. Case 3, May, 46, not bothersome tinnitus for many years. And it was just he was exposed to smoke alarm testing, and it was very unpleasant. Now, any alarm signal, even from distance, so relatively weak, induce very strong autonomic response. And still he likes loud music. And tried phonophobia, of course, the treatment phonophobia, 7 months of group therapy, 6 months individual session, and so on and so forth. Nothing helped, and actually his situation became worse. And by the way, one of the giveaway for misophonia is that typically misophonia, if not treated, is getting worse. Case 4, female 72, high frequency hearing loss, not tinnitus, introduced to hearing aids 5 years ago. And for her, typewriter and typing sound had always, and just how it sounded, she was describing. It's not that the sound was really loud. It's using hearing aids, and for her it's a problem because when she was using hearing aids, the tapping sounds are more intrusive. And again, she got a very typical advice, have to get used to it, which unfortunately is not helpful. Tried copying, no positive result. 5, female 29. And what's interesting, Asperger's syndrome, with a group of patients with a different variant of autism, including with Asperger's syndrome, which interestingly are reacting in very positive manner to treatment, like for misophonia. And as you know, it's a quite complex issue, and etiology of decreased sound tolerance in case of Asperger or autism is not clear. And for this patient, for her, eating, breathing sound are bothersome. And again, less problem at home, and even smell of some foods induce ear reaction, tension, pain. So again, misophonia, or reaction, which we are calling misophonia, involve reaction not only to sound, but to other sensory modalities as well. Trade, avoidance, and therapy for sensory overload with occupational therapies failed. And now, again, sounds can be different. You have a different ages, not only young people. Triggers are not only related to eating, as popular mass media are trying to convince us. And untreated misophonia frequently is nearly, I think, close to 100%. It's getting worse with time if it's not treated. So, mechanism of misophonia, as I mentioned on this diagram, enhancement, functional connection of this connection between auditory system and limbic system. So, auditory system works perfectly fine, but certain sounds are causing abnormally strong reaction, excitation of limbic and autonomic nervous system. Treatment with TRT. misophonia need to be treated at the same time as other problems like tinnitus, hyperacusis, and I'll be showing at the very end what is happening if you are not doing this. We create like 4 different categories of protocols for treating misophonia. Quite frequent, but not always, we're using ear-level sound generators, who are particularly helpful in a situation like a school when patient has no control over the environment. Duration is not as fast in case of hyperacusis. Hyperacusis is faster, but it's more similar to duration of tinnitus. We publish success rate 83%, and what's interesting, that in many cases, it is possible to achieve a cure. That means patient is as good as never having misophonia. It's as well, we're getting improvement in reaction to other sounds, somato sounds, and I'm not going to talk about this today, but as well is very helpful in treating tensor tympani syndrome, means pain in the ear, fullness in the ear, pulsation in the ear, and so on. Now, in the treating of both hyperacusis and misophonia using sound, and we're using principle of contrast, that means that people are judging strength of any sensory stimulus not as its absolute physical value, but as a beginning comparing the background. So with external sound and with a background neuronal activity, which is controlled by background sound, the stimulus, for example, sound of eating, is that big. Now, what we can do by increasing background activity, by adding extra sound, we are decreasing effectively from point of view of brain the signal. So from that big, we're getting that signal, and then it's easier for brain to do something with this signal, for example, achieve habituation. And here sound generators are very helpful because they allow for very precise adjusting in controlling sound level and create like a different thickness shield between patient and external sound environment. And because of this, avoid silence is typical recommendation using different type of approaches. And I would like to stress one thing: if you are going to have anything to do with patients, the thing which I believe is very important, that sound which are using in sound therapy should not evoke annoyance, discomfort, or any other problems, because when you are stimulating in negative way limbic system, and they are basically working against yourself. Now it's a substantial difference in treatment between hyperacusis and misophonia, and what works for hyperacusis is not effective for misophonia, and what works for misophonia, it has a limited useful for hyperacusis. And while using methods which are arising from active extinction of condition reflexes, and when we have both hyperacusis and misophonia in a patient, which is typical case, you need to treat both of them concurrently. You just cannot just let's treat hyperacusis now and misophonia later, or other way around. Effectiveness, we published this in 2014, 201 consecutive patients with decreased sound tolerance. We got 83% significantly improved, and as I mentioned, in many cases we have a cure for misophonia. Effectiveness for hyperacusis and misophonia were very similar. Now I would like to show you this case, which is my favorite case because it's showing how I was miserably failing for 7 years treating patient because of misdiagnosis. And misdiagnosis was because I was treating patient before concept of misophonia was introduced. So patient was, absolutely devastated by decreased sound tolerance, cannot move out of the house practically. And I diagnosed him 7 years earlier, before I start now talking about this case, for tinnitus and hyperacusis. I was using different things. I was treating him to the best of my knowledge. When I got 7 years later, real year measurements show that he was using sound generators at too low level, threshold of hearing, which actually is enhancing tinnitus. Tried different things. I just mentioned two, but the list of things he tried was very long. And he was from California, so it was across continent, wasn't easy to communicate. So you have a severity of decreased sound tolerance 8.5, annoyance 10, effect on life 9, all of this on scale from 0 to 10. So he was basically disabled with his description, and many sounds were very bothersome for him. All life activities were affected, and as I mentioned, he was just living at home. Luckily for him, he was able to work from home. His line of work allowed, so he was at home arrest. And what was interesting, now I can recognize it at once, but exposure to sound worsened decreased sound tolerance for days. And at this time, he was classified in the so-called category 4 of tinnitus patient, which was totally incorrect in his case because he had just misophonia, and misophonic patient, this is quite frequently reported. So have his audiogram, and please notice his loudness discomfort level in the range of 60, 70, which can happen in case of a hyperacusis as well in misophonia, but in misophonia you can have a normal value as well. So what is interesting, well, his decreased sound tolerance was really very bad. Tinnitus secondary but significant, and he was treated for 7 years, to the best of my knowledge, without any positive effect for neither tinnitus nor decreased sound tolerance. I was using incorrectly sound generator, and I did not know when I first met him 7 years earlier that he had a misophonia and not hyperacusis. And he might have some hyperacusis, but not too much. The level of his anxiety was extremely high. He was totally disabled by decreased sound tolerance and long distance. So what we did, all the cases, I think 90-something slides, I just pick up the most interesting points and crucial for treatment. So in reality, he was tinnitus with strong misophonia. He got counseling and so on. And again, for first 9 months, he was still treated like for tinnitus and hyperacusis, because misophonia was discovered, introduced when he was more or less in 9 months in the second phase of a treatment. So 7 years, nothing. Then 9 months, still incorrect treatment, but with a correctly set sound generators, so instrumentation was fine. Now, at 9 months, protocol for misophonia was introduced, and then you have a number of follow-up visits. So what we have? 5 months, patient showed still hyperacusis and tinnitus, no misophonia. So improvement in LDLs, although improvement decreased sound tolerance was rather weak. What has happened that once he started using properly sound generators, his LDLs improved, but he was still pretty miserable. In 9 months, protocol for misophonia. And now I would say that this was point when he started getting proper treatment, normal treatment. 1 month after this, feeling much better, report some improvement, still have some problem with sound tolerance, but not only him, but his family reported improvement 1 month after introducing proper treatment. 12 months, tinnitus not significant anymore. 3 months after beginning of his treatment. And remember, for 7 years, no change. 16 months, big improvement in DST. He was amazed. If it's in quote, it's just his direct words. 23, amazing progress. Doing nearly everything. 10 years since he got decreased sound tolerance. 34, went to Las Vegas, no problem, file close. And I was getting with him longer, and actually he's still sending Christmas card or so I know that he's fine. What he reported during this follow-ups, it was like being in jail for 10 years and I'm out of jail. First time I was in movie theater after 10 years, the tears of joy and so on. wonderful state, I'm feeling great, and so on and so forth. He was absolutely fine. We got the cure for basically all of his problem. Now, if you look at the scale 0 to 10, this is decreased sound tolerance, this is tinnitus. So tinnitus was 6, and proper improvement sound generator improved with a little bit, but after introducing protocol for misophonia, please notice that his decreased sound tolerance start improving very rapidly, and tinnitus as well. If you look at the average LDLs, improved after proper setting of sound generators, but we started from 60 something. At the end, we get a 110 average LDLs. Now, THI, tinnitus handicap inventory. This is the state he was for 7 years. Basically, sound fluctuation is stable. This protocol for misophonia. 2 months later, he dropped to 0 and then got a 2. So basically, tinnitus definitely ceased to be any problem. So what I would like to point out that treatment for misophonia and hyperacusis really must be different. I was treating him for best method for hyperacusis and I was failing. Introducing very basic protocol for misophonia helped enormously. So we need the special protocol. Again, like in his case, and he's not the only one, I just pick up because he was so spectacular. We achieve a cure. And as you notice that I was failing in his tinnitus control. But after treating misophonia, he got full recovery from tinnitus as well. So thank you very much for your attention, and I will be very happy to answer any question you might have. And I think that I'm a little bit 10 minutes above the limit. I hope that you forgive me.
And we'll now open it up. I was seeing a young girl that was having problems, but it was only with her father, and it was only when he was chewing. And I assumed it must be a problem with the father-daughter relationship rather than misophonia, because it was just that one person, and it was just that
not necessarily. What you are describing is, well, I had no time and possibility of getting the mechanism, but something which is this called, I mentioned, complex condition stimuli. It's a concept in behavior which is not as popular. I was lucky enough that I was last student of Professor Konorski, who was student and competitor of Pawel, who actually invented operant conditioning, which he was calling instrumental reflexes, as well as he introduced concept of brain plasticity. And I was arguing with him all the time. I was a very bad student, but he forced me to learn a little bit. And one of the things which I learned from him is issue of a concept condition stimuli. And there are a number of examples. I published some of them, which are shown. But if you take something, let's say sound, but this sound you put in a different place, for example, in different room, or sound may be a different person, the reaction to the sound can be totally, diametrically different. Because what we are reacting to is not only sound, like for example, voice only, but sound generated by certain person in a certain place. So for example, this girl can react to sound of eating of only her father and nobody else. And the beginning might be that she had a tough time with her father during the eating. Like I gave this example of this girl who had a problem with grandfather. And when she was 12, was forced to sit at the table, grandfather, which was eating in a very nasty, unpleasant manner. And then, if it's not treated or given enough time, this is spreading. It's another so-called generalization principle. It's spreading on other sounds and other people. So what you describe, it might be, as you know, the father-daughter reaction, but it is possible that it is just plain normal misophonia, and you need to dig in a little bit deeper. Which other people might be involved, which other sound might be or not involved, and then you can decide is it just psychological aspect of father-daughter relation of cerebral misophonia. And other cases when, for example, movement of mother hands, but only mother on the steering wheel of a car, were highly unpleasant, and the same thing generated by father were not. So she was driven to the clinic by her father, not her mother. So, and again, it has a very good neurophysiological explanation if you get into this, and some of the cases I described, one even is in this classical 1990 paper on tinnitus phantom auditory perception. So it's unfortunately not sufficiently recognized, but it's common. It's one of the common issue of misophonia. But who is making sound and where the sound is produced plays a fundamental role.
Diana and Chris would like to know specifically how treatments for hyperacusis and misophonia differ, and what does the treatment for misophonia involve?
Easy question, providing that you give me about a day. Our course, diagnosis and treatment of decreased sound tolerance out of 5 days is probably 2 days. But I can provide you a very brief nutshell type of a response. Hyperacusis seems to be, and the result of a treatment support this postulate, be related to abnormal enhanced activity inside of a subconscious auditory paths. So, and there are some animal data for this and human. So what we are doing by providing patient with 24/7 constant, gentle, neutral sound which is not inducing annoyance, and is as high as you can be, but without using this annoyance. And we, in our publication, we have a special, like a triangle showing this, allows for removing hyperacusis or decreasing or even removing hyperacusis reasonably fast, 2-3 months. And patients do not need to even understand what's going on as long as it's following this protocol. In case of misophonia, problem is in abnormal function connection for specific sounds. And it's much more complex. We're using different principles of the brain function and changing condition reflexes. And I mentioned these 4 different protocols for misophonia. The first one was published in 2002. And patients, in addition to, avoiding silence and blah, 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 we are doing specific exercise once, twice a day, and in which the common feature of this is to create positive association between sound in general and, well, feeling better in case of a patient. And one of the protocol, most difficult one, involves creating complex conditioned stimulus with bad sound, misophonic trigger, immersing this in positive sound and other positive association, positive sensory things. But easiest thing to, like an analogy, which actually in some patient can be used. Patient who has an aversion or strong reaction to sound of eating is getting, as one of its protocol recommendation, to have twice a week or so eating with people whose sound of eating is creating problem, but in the same time playing some of a favorite sound, not loud enough to mask the sound of eating, but it make it weaker according to this principle, which I show on one of the slides, and as well having some other nice thing, for example, nice atmospheres, tasty food, or whatever else. Just trying to add positive things from other sensory modalities. Another example is the boy who had a huge problem with cracking, like a cracking of the joints and so on, and who loved at the same time chocolate cookies, chocolate chip cookies. So his exercise was doing exercise when he was breaking freshly baked cookies with a beautiful smell of cookies, So he had a positive aspect of this cookies, which he loved, at the same time cracking sound. This is just, only outline. To go into detail, I really would need to have much more time for this. But bottom line is that it can be done. And for 83% of a patient, works very nicely. But it's complex. And each patient needs to be addressed individually. You cannot just give one method for all. For hyperacusis, it's much easier. Yes, for hyperacusis, just patient need to know use the sound all the time and 24/7, day and night, including night auditory system up to the level of inferior colliculus works perfectly well when we are sleeping.
And Grant Searchfield wants to know if you think a single medical drug will be able to treat hyperacusis or misophonia, or a combination of drugs, or is it too complicated for medications?
I strongly believe that it's impossible. In case of hyperacusis, perhaps. It might, I don't know, one drug, combination of a drug, it might, because it might be possible to reverse this overactivation. In case of misophonia, it's practically by definition it's impossible, because misophonia is a pattern. That means you will need to block pattern recognition so badly that patient would not be able to recognize any patterns. Just using analogy from the tinnitus field, when just for tinnitus, for nothing else, in England in the 60s did prefrontal lobotomy, and 19 out of 20 patients survived nicely for surviving, and they did not care about tinnitus at all, but they did not care about anything else at all. So I'm afraid that in this case, to achieve a situation that misophonic patient will be not reacting for specific patient, you need to do something very dramatic, or they have no emotion to basically anything, or they are unable to recognize patterns of sound. So I personally don't believe so. Hyperacusis, yes, misophonia, no.
And Heather T wants to know how long you would use the 24/7 noise for hyperacusis, and does it reduce over time? And I'm assuming the noise rather than the hyperacusis, but I'm not sure.
First of all, I will use sound, not noise. Word noise has English language negative connotation. In this case, we're trying to use sound which is neutral or have a slightly positive connotation. I'm promoting idea of using sound of nature, particularly sound of gently flowing water, because of a number, again, physiological things. We have a general preference, a human being, to sound of gently flowing water. Water is a sound of life, and we need water to survive. And from a practical point of view, it's easier for patient to habituate to ignore sound of nature, sound of water, even at the higher level, but any other artificial sound. And sound of work of Henry and actually Grant Searchfield indicate that sound which resembles sound of nature are better tolerated by patient. How long? I would say that avoid silence in case of hyperacusis, particularly day and night, is through all the treatment. And I'm getting patient gradually from this. That means patient have a control of this, and it's getting gradually. But as long as patient the treatment, and I'm using a little bit arbitrary duration 9 months. That even if patient is getting wonderful before this, I insist that by following some of my advice for 9 months to prevent relapse. And basically, I'm not observing relapse in my patients at all. At all. It means very, very on very, very rare occasion. So use sound 24/7 is for duration of a treatment. And if patient is in hyperacusis after 3 months, wonderful. I'm saying, I'm sorry, please keep for longer period of time. I don't want to see you relapse. But if patient is fine after 9 months, I say, okay, that's enough.
Catherine Davis wants to know if it's related to CAPD. or APD, sorry, and is the treatment accepted in New Zealand, worldwide, and is it available in New Zealand?
If it is available in New Zealand, I have no idea whatsoever. My last course in New Zealand was quite a number of years ago, and we are teaching, really treating misophonia more intensively for like last 10 years, and actually last 5 years. It is in United States, it's definitely in our hands, and we are teaching this in our courses. Last year, we have a 50 actually course in the United States, during which we're teaching treatment for misophonia and hyperacusis. It is recognized. I would say that it is in the one of treatment which is not fully accepted, but is not put that, well, you should not be doing this. As you know, probably CBT is now considered to be leading method for treating of everything, tinnitus, hyperacusis, misophonia. I do not believe this. I believe that CBT is effective to some extent in some patients, but it's mainly improving coping and not removing problem itself. I don't believe that CBT can remove itself without sound therapy and some can remove hyperacusis or misophonia, but of course I can be mistaken. It is used in a number of countries. TRT as a TRT is used in over 30 countries, different versions. People who went through a more recent courses, our courses are using as well treatment for misophonia, but still it's not too many places who are doing this. It's more difficult, to put it bluntly.
Marianne Kruger wants to, or she sleeps with earplugs and cannot sleep without them. Any advice to get off the earplugs so she'll be able to fall asleep?
Yes. Yes, definitely. It's unfortunately very, very common situation, very difficult situation, because using earplugs is one of the best methods for, it's an effective method for inducing hyperacusis, even if somebody has no hyperacusis. For misophonia, it's not that relevant, but it's not helpful either. What I'm recommending patient, and it's one of the questions, for example, our question is always about favorite sound, not which sound I am getting information which sound they don't like, but as well information which sound they like very much, which sound they love. And actually, so one of the protocol for misophonia. So I'm now suggesting patient to use the sound which they like very much during the day, and then start using them during the night, adding extra precaution that sound level for falling asleep should not be loud enough to create problem with falling asleep. And since we're using sound that people are liking, and I'm using saying, you know, it was song in the 80s, don't worry, be happy. I'm telling my patient, probably I'm recognized from the store, don't worry, be happier. I don't need you to be happy that you are listening to some sound, but be a little bit happier and just have a more relaxed, nice feeling. And then I haven't had a patient on whom I would not be able to introduce sound during the night as well. And again, as well, get out of using earplugs, which were another problem, so-called auditory toughening. By overusing earplugs, actually, were increasing chance that accidents are exposed to loud sound. You have a higher chance of getting hearing loss, permanent hearing loss, because auditory system is getting too delicate. And it's a lot of study on this auditory toughening, auditory conditioning, both on animal and humans, which indicate that if our auditory system is not getting enough sound, we're just increasing chance of getting damaged. So you need to have a certain balance. Too much is bad, but too little is bad either.
With that, I want to thank Dr. Jastreboff for his time today. I know it's evening in the United States, so we appreciate you taking your evening to share that information with us. There is so much information that was presented today. We will be having the presentation put up on our website in the next couple of days. There was a request for your presentation, Dr. Jastreboff, if you'd be willing to share that with us. The PowerPoint presentation.
Sure, I'll be glad. I will get to send to you with out, since you know, as presentation is not as nicely flowing as I wish and as well organized. I don't like. I'm not very good in presenting short things. It's much easier for me to make a 2 hours presentation. So if it can be somehow restricted to the organization also and not you know everybody, my verbal presentation or video, I don't mind. You can do whatever. And actually, I'm stupid because if I'm saying visual, that means you have a PowerPoint too. Sorry. So it's okay with understanding that it's not perfect.
Now, you mentioned that you do an online course. Is that available for people to take from New Zealand if we want to get up in the middle of the night?
Well, if people from Australia are welcome, I think that people from New Zealand will be even more welcome. And during class courses, we have like 4 people from Australia who switch day and night, and they were just attending course during the nights. So of course, well, very, very welcome. And we have people from different countries all around the world. At this moment, I would suggest that if somebody is interested to send me email on this email address, so I can put on the so-called waiting list while restricting number of people now, of course. Initially, it was 15, hit even 30, but at this moment, I have about 100 people who express interest, and of course, out of our 100 to be less, but it's better that I have on the early list, because when I'm just using who already is on the list, have a priority comparing with people who are just deciding to join the last moment.
Our next month, we will be having Dr. Wyatt Page, who will be speaking on the WHO guidelines for community noise. As we know, it is not just loud noises that can cause hearing loss, but the modern world that we live in, and the noise is also problematic. If you enjoyed today's presentation, you can always make a donation to Hearing New Zealand and support the lives of people living with hearing loss. And that's on our donation button. And as I said, I want to thank Dr. Jastreboff, and we will be sending that out. If you have any additional questions, he's given you his email, and I can verify that he answers emails incredibly well.
Trying to. I'm not as good as Lisa is saying, but I'm trying. I'm trying to behave.
And we'll send out links to your class also, if you'll send those to us for Chris and anybody that wants to do that one.
Sure, I'll be glad to do it. I'll be glad to provide you with information, advanced information about class. We are hopefully planning to offer a class sometime summer this year. Last year we have more courses, but this year is more crazy than usual, for me at least. Thank you very much, and thank you very much again for invitation and creating chance of offering some of my thoughts.
Thank you very much. And with that, I'm going to end the presentation. Have a good lunch, people.
Thank you. Thank you. Goodbye.